It is my privilege to welcome you to the scientific session on congenital glaucoma. This session brings together leading experts and dedicated professionals who are committed to advance our understanding and treatment of this challenging condition, the congenital glaucoma. Pediatric glaucoma encompasses a range of complex disorders. If left untreated, can lead to irreversible vision loss. Our focus today will be on exploring the pioneering surgical techniques and clinical management strategies that are pivotal in monitoring, in managing for the better outcomes. So I look forward to an engaging and informative session here. Let me introduce our panelists for today. I'm delighted to introduce Dr. Levin, a renowned expert in pediatric ophthalmology and ocular genetics. Dr. Levin serves as a chief of the Eye Institute Pediatric Ophthalmology and Ocular Genetic Team and chief of clinical genetics at University of Rochester, New York. With the medical degree from Jefferson Medical College and extensive training in pediatric ophthalmology and bioethics, Dr. Levin is uniquely positioned as the only physician worldwide to hold US board certificates in pediatrics, ophthalmology, and child abuse pediatrics simultaneously. With over 35 years of experience, he is highly regarded for his expertise in treating various pediatric eye conditions and genetic disorders. Dr. Levin's impressive career includes extensive research, hundreds of peer-reviewed publications, and numerous awards. Please join me in welcoming Dr. Alex Levin in our congenital glaucoma panel discussion. Please, Dr. Levin. Have a seat there. Our next panelist it's an honor to introduce Professor Surat Noorani, a highly esteemed pediatric ophthalmologist and pediatric glaucoma consultant. Dr. Noorani currently serves as a consultant in pediatric glaucoma at Qatar University. With over 50 national and international publications, Professor Noorani is a prolific clinical researcher and authored book chapters published by the American Academy of Pediatrics and Oxford Publication. Her special interests include pediatric cataract, pediatric glaucoma, retinoblastoma, and ROP management. Professor Noorani was awarded a gold medal by OSP Pakistan for her outstanding services in pediatric ophthalmology. Please join me in welcoming Dr. Noorani to our panel discussion. I'm excited to present Dr. Ali Ayaz, currently the professor and head of the ophthalmology department at KEMU. Dr. Ayaz specialized in pediatric ophthalmology and strabismus. With the fellowship training in USA at Howard, Dr. Ayaz has become a prominent figure in pediatric eye care. His work combines surgical precision and intellectual challenge, making him an invaluable member of our panel today. Please join me in welcoming Dr. Ali Ayaz Sadiq. We are still waiting for another panelist, Dr. Ashal Paul. I'll introduce him later on. So and as myself, I'm HOD and chairperson pediatric ophthalmology services in University of Child Health Sciences and Children's Hospital. And I recently joined the department. So the consent taken for all the patient pics, but still I would request not to take the pictures of the patients. The congenital glaucoma, it's a heterogeneous disease, pediatric glaucoma, and it's based on the age, and it is classified as the congenital glaucoma, infantile glaucoma, and juvenile glaucoma. Today our focus will be on congenital glaucoma. So let's begin with the case. So a 3-month-old child, baby boy, was brought with a large cornea and different eye colors since birth. Mother was happy regarding the big eyes. On examination, on history, he was the first child, a product of cousin marriage, had bilateral large cornea, hepstria, and left iris heterochromia. His horizontal cornea diameters were 15 millimeter and 14 millimeters in right and left eye respectively. Pressures were 19 with Perkins under GA. Her cup disc ratio was 0.3 and 0.4. On refraction, there was a myopic shift, and axial lengths were 19.87 and 0.23 millimeters, respectively. So, my question to the panelists, especially Dr. Levin, how would you approach this patient? What are your pearls to start managing the child?
Thank you very much, and thank you for allowing me to be here. When we look at the classification system that the CGRN, the Congenital Glaucoma Research Network, came up with, I think it's important to go down the tree to get to this diagnosis. If the baby is systemically well, I would do a physical examination. If the baby has no other ocular malformations, then indeed the child has typical congenital glaucoma, which is therefore classified, and this would be the neonatal onset congenital glaucoma, all of which these findings are sufficient to make that diagnosis in the absence of those other findings. My goal goes to address the goniogenesis. And when there's a goniogenesis, we have to do some type of surgical procedure because in general we don't consider this a medical treatable condition. So I'd be aiming to do goniotomy, first line surgery, or speculotomy, depending on the clarity. And I would normally be starting some medication early just to clear the cornea a little bit to help with the view at surgery and go from there.
Okay, thank you. So we all know that there is a classical triad of photophobia, apiphobia, and blepharospasm. Does all the photophobic children are considered glaucoma suspect?
I think that's a fantastic question because I've seen many cases of children with missed glaucoma because these symptoms weren't recognized. But remember that the symptoms of epiphora, photophobia, and blepharospasm always mean the cornea is involved. So if the cornea is normal and normal size without edema, then the photophobia, epiphora, and blepharospasm are coming from something else. You have to have corneal involvement to get those symptoms. So therefore, I think looking at the cornea as the root of the problem, that's when I would want to evaluate. However, all children with these symptoms, of course, need to be considered as possible glaucoma, but if the cornea is normal, it's not coming from glaucoma.
Okay, good, great, thank you. So, what are the factors, what further symptom signs other than these three you would like to add on to narrow down the your diagnosis?
Well,
other than cornea.
Yeah, glaucoma is a puzzle, and we're taking all the pieces and putting them together to get a picture, right? And for me, you've got many of them here. We've got the corneal diameter, we've got the length of the eye, the size of the eye, gonioscopy when you can do it, diffraction, appearance of the optic nerve are all important. The least important thing is the pressure, because the pressure can be falsely low from the corneal epithelial edema. So the pressure is neither here nor there. And if this pressure was 12, I'd still know it's congenital glaucoma and would still proceed with treatment. So all of these things come into play, as well as the physical exam and the rest of the ocular exam, looking for malformations that may be subtle, posterior embryotoxin, etc., make the diagnosis of glaucoma.
Yeah. You mentioned that in a clear cornea, you will go for goniotomy.
Yeah, if there is a clear cornea, goniotomy is always my first choice. It's cheap, it's easy, it's fast. I can do it in a minute, literally, to do the surgery. Trabeculotomy harms the conjunctiva. It can be done 360, but then the rate of hyphema goes up. So I prefer not to injure the cornea. I don't even need to do a suture when I do a goniotomy, I want to need to suture the eye, just the 25 gauge needle. So there's so much advantage to doing a goniotomy with the same success rate, as far as we know, with that and even 360 trabeculotomy. If the cornea is cloudy, if it's really cloudy so that I can't even see my instruments, then I'm going to do a trabeculotomy or something like a trabeculotomy. If the cornea is mildly hazy, I can do an endoscopic goniotomy. But of course, these procedures depend on your comfort. And if you're not comfortable doing a goniotomy and you're not comfortable doing a trabeculotomy, then there are other procedures, trabeculectomy, for example, or the trabeculotomy-ectomy that was recommended by Professor Mandal in India, is done by many people in this part of the world. So comfort level is also an important factor in your choice.
So, is the clarity of the cornea the only thing you consider before deciding which surgery to opt for? Or the size of the cornea or other things, any?
I think that in a child who's got congenital glaucoma, who doesn't have aniridia or something else, you have to do surgery that's going to attack the angle. And you can attack it from the inside out or the outside in. And the easiest way inside out is a goniotomy. If you're not comfortable with that, then go outside in with a trabeculotomy or some procedure that's an equivalent. The problem with all the MIGS procedures and GAT and so on and so forth is the eye is so soft in a child that those procedures get a little bit more difficult to do. But if you're familiar with that and that's comfortable for you, that can also be done. They're much more expensive, of course, as well. So I take that into account.
Yeah, thank you. So you mentioned about the endoscopic goniotomy. Would you mind elaborating, because I have no experience of the endoscopic one.
Yeah.
Anyone on the audience have the experience with endoscopic goniotomy? Okay, good. So we will just first elaborate, Levin, and then we'll ask the audience that they share their experience as well.
Yeah, endoscopic goniotomy is a procedure that's a lot of fun to do. It's basically using the endoscope. You can put the camera in the eye and then put a needle in through a couple clock hours away, and you essentially do a goniotomy under full view. The only contraindication to that is aniridia. You don't want to put your endoscope in over without the iris to help you. Relative contraindication. And it's the same thing as a goniotomy, other than the fact that you're not viewing directly, you're viewing through the endoscope. The endoscope does come with a sleeve that would allow you to do it through one port, but that sleeve is a little wiggly, and I find it much easier with a second hand to do the 25 gauge needle.
So for that you need an assistant?
No, you can do that alone.
Okay. So thank you. From audience, someone raised the hand. Would you mind introduce yourself and share your experience, please?
Assalamu alaikum. Yeah, Karim Damji from Aga Khan University. So I was at the University of Ottawa, Alex, for many years, and I think we had met each other probably when you were in Toronto. We were doing endoscopic goniotomies on children with cloudy corneas, because I was used to using the endoscope for, cyclophotocoagulation and so on. And, I think it is useful technique. The comment I wanted to make was that, at least my experience here, seeing a lot of patients presenting, who have consanguinity, presenting very early in the first month or two, or even 3 months. And the glaucoma seems very aggressive and the corneas are quite cloudy. So I have tried goniotomy, but it doesn't seem to work as well as the Mandal option, and a lot of people are from far away, so I don't want to take a chance. So I usually end up doing trabeculotomy combined with trabeculectomy, and it seems to, handle that fairly well. But there were 1 or 2 papers I was just checking in the literature from Egypt and other places that if there's a strong family history, or at least of the consanguinity, if the presentations in the first month of life, goniotomy in this population may not work as well as a combined, for example. So I don't know what your thoughts are there.
That's a very important point, and you're absolutely 100% correct that the earlier and more severe the presentation, the less goniotomy works. Some people will not even try goniotomy. For me, goniotomy is so easy, so quick. It's easier on the baby, it's easier on me, it's easier on everyone, that if I can do it, it's worth taking that chance. And even if the success rate were 50% or 40%, I would go for it and give it a try, because your other options are more aggressive surgery, like the otomy or a tube. And if I can do a goniotomy, I will always try that, or a tracheotomy, I'll always try that first. But you're right, in these young babies, and we've just published a paper on consanguinity increases the risk of failure. Being from India increases the risk of failure. And I would still do it first if I can. Understanding, I would tell the family in advance, the success rate is lower.
Right. So I think it comes down to the communication with the family and also the geographic factors, right? Because we're seeing people from, hundreds or thousands of miles away. So if that's the case and they can't come for regular follow-up, then I sometimes go to what I feel is my, in my hands works better. Yeah.
So is there any difference in outcome? Yeah, sure. Yeah.
Dr. Levin, you taught me goniotomy, okay? And I started because I was so much impressed. We used to do trabeculotomy, lectomies a lot, and I was so much impressed that it's short time, it's just a 1 minute. The setting takes longer time when we sit opposite to each other and holding and rotating, abducting and adducting the eye, but the procedure itself was 1 minute. Taking your point, Dr. Saab, yes, he's right. In our so I started doing it when I joined back to Al-Shifa from coming back from Bullseye. Then I started doing goniotomies because I was excited to introduce a new procedure. And then I experienced that in our part of the world, the severity of the glaucoma is so much that they present early. And most of the eyes are hazy eyes. We can't do it. But as soon as I get the child with a clear cornea, I want to do goniotomy. Yeah, that was the choice. But the one positive thing I noted, that yes, it fails. It does fail, but I gain some time, If the pressure goes down, if the cornea is clear, if axial is not increasing, then that child, from 3 months, the child becomes 6 months. Okay, now my chance of doing trabeculectomy in my hands, 6 months and above, trab, which is combined, it really works well. So I buy those 3 months, and my chances of having successful trab is higher. So that's again the plus point of doing goniotomy in these cases. But we have to be careful because our families, they can't come for the follow-up. So if you're doing goniotomy, sending back this child, and that child will come back to you with 30 millimeter of axial length, not having any procedure. So follow-up is important. If you're doing goniotomy, you have to select the proper cases.
I think the follow-up is important in any procedure you do in pediatrics, especially. So you mentioned about the endogoniotomy. Is there any difference in the conventional and endo outcomes, in outcome, real outcome, or surgical failures or success outcomes?
It's the same as a goniotomy. It's just a goniotomy
But
assisted by
better visualization, do you think that it counts?
Doing the endoscope is just a matter of helping you see better. It's still the same procedure, and it's still the same outcome rate. It's still the same follow-up. Everything is the same. It's just you looked at it a different way.
Okay. So this child was, like we were discussing, was 3 months old. But if the child is, say, 5 to 10 days old, would you like to wait till he or she become 28 days old, or you would just go in?
It's a great question, because we know there is a rare entity of spontaneously resolved glaucoma. Anybody who does glaucoma has seen cases like this of kids who somehow they present at 1 year of age or something. They've got no glaucoma. They have hypostria. They got big corneas. Their disc is normal. Their pressure is normal. And we also know that postnatally, the trabecular washwork continues to develop. So if we waited, some of these kids would get better. But one can't wait. The kid has active glaucoma. It's not going to respond to medicine. It's a surgical disease. And throughout my career, the one thing that is the most disturbing is when I've realized that I've lost time and that now it's cupped. I can't go backwards. You can never go backwards in glaucoma. So you have to deal with what you have in front of you. And I would always treat, I would always do surgery in congenital or infantile glaucoma.
Early as possible.
I don't wait.
Okay, good.
My medicines are just temporizing to the operation and to clear the cornea.
Your anesthesia team must be very brave.
Anesthesia?
Yeah.
Well, we are very
Because-
brave and we're very experienced with pediatric anesthesia, and you absolutely need to have that. And if you don't have that, then maybe you do wait. But for us, we don't care what the age of the baby is. It's no concern.
Okay, thank you. So, do you use any medication before surgery for goniotomy? Like the people, they use pilocarpine?
So
Something like that?
If the cornea is absolutely clear, I'll put the baby on timolol 0.25% and latanoprost or some other prostaglandin just for the few days till surgery. If the cornea is cloudy from corneal epithelial edema, not stromal, epithelial edema, I'll also add oral acetazolamide just for the few days before surgery. But I do not use pilocarpine before surgery. I know many people do. It does shallow the anterior chamber a bit, which makes goniotomy a little bit more difficult. There's some evidence that it may increase the rate of hyphema, so I don't do it. The only time I use another medication is in uveitic glaucoma, but that's another situation. So just go ahead and do it.
Okay, thank you. In certain centers, Dr. Surya, they use the mannitol pre-op. Do you have any experience with the mannitol giving to the baby just to keep the IOP down?
No, we also use oral acetazolamide.
No
5 to
mannitol.
15 mg per kg. If it's neonate, 5 mg, 5 to 8 mg per kg, but no mannitol. No.
So here in Pakistan, in our setting, we don't have the oral acetazolamide available, the drops. So, Dr. Ali, what do you do?
Is it liquid? You can make a suspension. It's not commercially available in the U.S. or Canada either. It has to be compounded as a suspension for oral acetazolamide. But that's what we use. I'll use 20 milligrams per kilogram per day, divided into 3 or 4 doses. And it's just for a few days up till surgery.
So, do you give the potassium supplements as well then, along with that? Potassium supplements?
Say that
Because
again?
We do monitor electrolytes.
No, we don't. There's no need for those few days that you're going to use it just before surgery. It's not going to cause any harm.
But in Qatar, they have the protocol. We have to talk to the pediatrician. We have to take it on board. And then we have to take the permission. They will do all the electrolytes and all the comprehensive material. And then we are allowed to.
Yeah, we don't do any of that. We just go ahead and give it. It's so harmless in such a short period.
So I agree that, one, you don't get commercially available suspension of acetamide as is. So you have to kind of get it compounded. There are pharmacies here which do it also. So if you go to Fazildin, for instance, they do it. And
Here also in Al-Shifa, we used to make in our pharmacy.
yeah, you can, anyone who has a facility to compound AZM can do it. Mannitol, no, I'm too scared to do that. And for a short period of time, potassium doesn't really have a problem. If you really want to be cautious and just get an electrolyte done, but usually see, you have to understand that any medicine that you're giving is just a temporizing thing. It's just a tool so that you can prepare for the surgery. In the US, for instance, you have time scheduling patients, and if you want to have something in that interim period, it makes sense. Here, if you're scheduling them for a couple of weeks, then you start with topical and then go to AZM right before. This is what I do usually. I usually start the topical if I feel there's going to be time in scheduling, and then a couple of days before the surgery, I start giving them AZM suspension. Don't want to give AZM for too long a time, but if you're giving it for a very short period of time, you don't need to really worry about potassium.
They do have their separate.
Sure.
And I don't have the authority to take follow them.
No, that's absolutely right. It depends on where you're working and what the SOPs there are.
But
But-
that home in Al-Shifa, we never
Uh,
monitor. Short period, and we used to tell parents to crush the tablets and put it in the, add it in the milk and give it to the child.
And if you're giving ACM for some time, back and driving back, Give a banana or a.
Sure, but so the point is A, whether it does really cause a depletion of potassium or no in such a short period of time. The answer is no. The other question is what happens at your institutes and what the SOPs are. It's open. So I don't think there's a right or wrong answer vis-a-vis giving potassium or not giving potassium. Some people give it, some people do the banana thing. All works. So there's no. As Alex initially said, glaucoma is one of the biggest. He said it's one of the puzzles in pediatric ophthalmology. I think it's one of the biggest puzzles because there's a spontaneous resolution going on. There is the question that you also asked. There is which procedure to do when, and for such cases, because there's potential blindness that you're dealing with, you're kind of on your toes as is. But my principle is keep it as simple as possible and just take one thing at a time. And the question that you asked earlier, goniotomy versus trabeculotomy, what time you should be doing. I like to go in early. If the corneas are clear, just do it. Because the reason I don't like to do trabeculotomy earlier is because I want to, as you said, I want to maintain the conch and I want to maintain as much architecture of the eye as possible for as long as I can. So, goniotomy in Asians and especially pigmented eyes has a lesser success rate, but it gives you a few years to play around with it. So it's simple for me. KIS, keep it simple.
The other S is for stupid, right?
Yeah, I know.
Regarding the pre-op medication, I would like to know what is your opinion about using systemic steroids in such persons?
So you're asking me, you're asking Alex, or it's open?
I'm asking all of you.
So I don't give steroid drops pre-op. I just don't, unless it's a UVA.
No. Okay.
So because see, you have to understand that the problem of so it's dysgenesis, and steroids have been shown to cause more problems there. But I just don't give it. I don't know what Alex does.
I don't give steroids unless it's uveitic glaucoma.
You are saying in trabeculectomy or trabeculotomy? I'm sorry, I'm late.
In any operation,
Pre-op.
Pre-op.
in any operation, I don't.
And
give
post-op?
steroids.
Systemic steroids. In cases of trabeculectomy.
Systemic? No.
In my experience, what I would like to say, that in children, healing power is much more and they heal very rapidly. But I have seen in which we use systemic steroids in cases of trabeculectomy, results are better as compared to not using systemic steroids. It's my personal experience.
And you start it when?
I start before surgery,
And how many days before surgery?
around 4 or 5 days.
Okay.
So if the baby is, say, baby is like 15 days old or 20 days old, you'll start the systemic steroid.
I think that.
Not in cases of even the patient is not having inflammation.
That's
Okay.
an interesting approach. I'm not aware of it being published, but I can say that in North America, trabeculectomy is very, very, very rarely used anymore in children. I know here it's used a lot more. And when we use trabeculectomy, we always use it with mitomycin because of the healing problem. And also, although systemic steroids have a risk even in first couple weeks, so we try and avoid that. But I would say that you probably have more experience than I do with trabeculectomy because we use it so infrequently in North America.
It's quite possible racial difference because there are risk factors, and in children, healing, I think everybody knows the healing is very rapid. So what I have observed in our population, if you use if we use pre-op steroids and, if you use systemic steroids, results are better because before mitomycin, this was the only thing available as immunomodulator. And this is acting as an immunomodulator as well.
So you're using pre-op steroids even when you're using MMC?
Yes,
And you're using MMC in all of them?
yeah.
We should publish this. It would be interesting to see what.
Very well.
I think
Yeah.
I would not respond.
You are very right. If you watch them very closely. The patient of cases of pediatric glaucoma and congenital trabeculectomy has been done. Sometimes you have to use all ways of immunomodulation because they usually start to fail in few months time. If we use steroids, results are better as compared to not to using steroids.
so. How,
Pardon?
Sir, you're using it post-op systemic also?
Yes.
How long?
For around about 6 weeks.
6 weeks post-op systemic.
4 to 6 weeks in tapering dose.
Okay.
In tapering.
So,
1 milligram per kg body weight, then tapering it.
okay,
if I can offer just
It is available in syrup form, syrup steroid.
if I can offer just a point of view on this, this is a very good example of one of the problems we have in disorders like pediatric glaucoma that are so rare. Certainly, using oral steroids, as I'm a pediatrician, and I would say oral steroids have a significant health risk after the first 14 days, first 12 days. So putting that aside, it's hard to do research in pediatric glaucoma. What we need for ideas like this are randomized trials, right? In lieu of that, because randomized trials are hard to do, we have an international pediatric glaucoma registry that's hosted in Rochester, New York. We have over 1,000 cases from 20 countries in the world. There's no center in Pakistan, and I would certainly invite a center in Pakistan to join. And this allows us to take large amounts of experience in a rare disorder to gather information to better analyze treatments like this. So for an idea like this, I would invite you to join the registry, put all your cases in the registry, and then we could easily compare retrospectively from around the world, your experience to the experience of others. That's the way we can leverage research for different ideas like this to get some answers. We could discuss all we want in this room, but really we need some more concrete research to show that certain options are better than other options. And the registry allows us to do this. And it's free, by the way,
That's
completely
good
free.
idea. That's good idea. Oh, and I'm sorry, I just noted the topic. I'm sorry I distracted you people. The topic is pre-op consideration of goniotomy. I thought it is trabeculectomy. I'm really sorry for that.
it's okay, it's a panel discussion.
Sorry for
Dr.
that.
It's okay, it's okay. So let's come to the nitty gritty of the goniotomy. So what position do you sit in while doing the goniotomy? Head end or side?
I sit temporally. I use a 25 gauge needle and viscoelastic, and that's all I do. Put a beveled wound right into the eye, do my goniotomy, put Helon in at the end, and people get worried about Helon, but you just created a big cleft. The Helon's got a place to go, and come out and I'm done. Patch and shield the eye. Don't give any subconjunctival drops. I don't give atropine. Just a little antibiotic and some topical steroid.
Okay.
With all due respect to my friend, Dr. Kohuk, who I know well, I don't see any advantage to that at all. And it's an added expense as well. I don't think it's ever been shown that the hook blade is any better than goniotomy itself. 25 gauge needle is a lot cheaper and more available. What length do I use? You have to use a short 25 gauge. Even in a 20,
No, the lens,
even in a
lens,
15
gonio
millimeter.
lens.
What's that?
Lens.
Oh, there's a lot of options. I use a free held Barkhand lens and I hold it myself with the forceps of the fixation hole. You can use a Barkhand lens that sews on the eye, but then you don't have the movement. I like a small, a preemie size, which I can move around in the eye. So I can really get you, if there's a hobstria, you can move the lens and see around the hobstria. That gives me more flexibility. There's the Swan Jacobs lens, which is essentially a Barkhand lens attached to a stick that you can hold. I don't like that as much. Everybody has their own preference. There's no right or wrong.
Dr. Sudat, your experience with the lens, which one do you use?
Yeah, Dr. Levin taught me with Parkins, but when I came back to Alshifa, we had Swan Jacob. So I had to use that and I feel comfortable with it as well.
So it's depend on the availability, not the choice.
No, if you want to, when I went to Qatar, they asked me if I want to order something, I order Parkins because it's my teacher's choice and I was trained to do that.
Okay. Yeah. Thank you.
You don't wash them, in the end.
Well, I don't wash it out. No, I leave the Helon in the eye, and they're fine. One thing I will say about the Barkhand lenses and the Swan Jacobs lenses, you must sterilize them appropriately. They're expensive. That's $350 for the lens, and if you don't clean it properly, it'll develop cracks, it'll degenerate. So proper sterilization is important.
Okay. Thank you. So anyone is open for the audience and the panelists. How does the goniotomy different from gonio-assisted transluminal trabeculotomy (GAT)? How is it different from that?
But it's very similar. I mean, there's many MIGS procedures, right? And the MIGS procedure where you inject the what's it called? The proline around. I mean, or you thread a proline or you inject a proline. I mean, they're all doing the same thing. It's a matter of your comfort level. But the eye is so soft in the baby that you don't want to be in there a long time. The eye will just get progressively softer and softer, and it's hard. So I try and be in as quickly as possible, just like that top photo in the column there on the left. The eye and the Helon helps things stay firm. That's why I prefer to do it from the outside in rather than the inside out.
Okay, good. So
I'm sorry, from the inside out, not the outside in.
the other way around, yeah. So how do you manage follow-up complications like hemorrhage if it happened while doing the procedure? So would you abandon the procedure? You would remove the hemorrhage blood from the AC, or what would you do?
So with a simple goniotomy, the hyphema rate is 50%. I can tell you that in 35 years or more of doing this, I've never had to remove a hyphema. The only time is in neurofibromatosis. Neurofibromatosis, they have a higher tendency to bleed. But in simple congenital glaucoma, it will always go away. You just made this big hole. Sometimes it's fabulous. You make your cleft, there's bleeding, you can use the Helon to control it, and you see the blood go right out of the eye through your cleft. It's wonderful. But it'll go away. Just give it time.
And what about the lens touch? If you touch the lens into your capsule?
The answer is don't touch the lens.
Yeah, but
That's
it's
another
a
advantage.
learning curve because
Helon is
Helon.
your friend.
Yeah.
Helon is your friend. So if you're using Helon, so a lot of times I've seen people try goniotomy with Visco. Please don't do that. Helon is your friend. It gives you such a good cleavage, if you will. You can just go in and you just out immediately.
And it stops the bleeding,
It
too.
stops the bleeding also. So it gives you this tamponade also. And sitting on the side versus sitting at the top doesn't really matter. What matters is you just do it well and you do it as swiftly as possible. So Helon is heaven sent as far as goniotomies are concerned. And the other thing, this hyphemas or Helon, you've created this huge area for it to drain. it drains immediately.
Helon can also be used to move blood out of the way so you can see, air sometimes comes out with the Helon, you can move the air bubble away. And I should also add, I've operated many times in India. The homemade viscoelastic in India can also be used just as well as Helon. It's not as crystal clear as Helon, but it's less expensive and works very nicely as well. What's it called, the one from India? Yeah.
And always keep an eye on the needle and keep it parallel to the iris. These are the tips you gave me, Dr. Levin.
It's,
That always keep an eye on your needle, and you need to have stable hands. It should be done by an experienced surgeon. Get trained first and then step by step.
Okay, thank you.
So what is your last limit of corneal diameters to go with the goniotomy?
you can use a short 25 gauge needle to a 15.
The corneal diameter.
What about corneal diameter?
Yeah. What maximum corneal diameter you will go for with goniotomy?
That doesn't matter to me. I mean, if the eye has got congenital glaucoma, regardless of the corneal diameter, I can do it with a goniotomy. A short 25 will reach across a 16 millimeter cornea.
So is there any difference of the complication in short, smaller diameter corneas and bigger corneas?
I'm not sure I understand the question.
So is there any difference
He's
between the
asking that if there is a difference in the size of the cornea, do you get the more complications if the cornea is larger?
Not that I'm aware of. All I would say is if it's true congenital glaucoma present at birth, you're going to have a bigger eye, right? And the bigger the eye means the longer it's been going on. And yes, the more severe, youngest cases have a lower success rate with goniotomy, for sure. But the size of the cornea doesn't affect my approach. I might be telling the family that the success rate of goniotomy is less. I might be telling the family that the chance of needing medication postoperatively is higher, but it's not going to change what I do.
You have to understand that the only limitation between a trabeculotomy and a goniotomy is the clarity of the cornea.
that can be overcome by the endoscopic goniotomy, no?
Ji, sir, so what?
So you can do endoscopic goniotomy
Sure.
in the hazy corneas as well, na?
Sir.
But is my understanding and their literature is that the surgical procedures is indication of the surgical procedure depend upon the size of the cornea and intraocular pressures.
Not
Say
that,
your
not-
cornea is bigger than 15 millimeters, don't straightforward go for the filtration surgeries, or even in the goniotomy, you have to reduce the intraocular pressure by doing cyclodestructive procedures first. So the chances of having post-operative complication or intraoperative complication in bigger corneas are more than the smaller corneas.
Not in my experience and not in the experience of the registry from over 20 countries and 4 continents and over 1,000 cases. They're the same. The corneal diameter is not a predictor. Corneal diameter is a predictor of the need for surgery. That's a paper we're writing right now, but it's not a predictor of the outcome of surgery.
But you have to understand one thing.
But for
So-
goniotomy,
so-
he's not dealing with the liver, it's private liver. For goniotomy,
So one, you have to understand what the pathogenesis is. It's your the angles not being formed. B, as Alex rightly mentioned, what you're doing with both procedures is just opening those up. So either you can do it from inside out or outside in. But the procedure primarily remains the same. I know what you're basically talking about, if the diameter is high, the sclera is going to be thin, and the anatomy changes.
You might get the Schlimm's canal at that level where you want to be there. So you are only removing the membrane from the peripheral vessel. You are not changing the diameter of the Schlimm's canal. Ultimately, the excess will go to the Schlimm's canal, and from the Schlimm's canal, it will drain into the circulation.
So if your anatomy is not right, not there, then in bigger corneas, the failure rate is more of goniotomy than the average size 13.5 millimeter corneas, even 13 millimeter corneas. This is my point. The whole anatomy of the trabecular angle of the antechamber changes.
Again, that's a very good point. And I would just go back to what I said originally is, as the glaucoma presents younger, the cornea is bigger, the cornea is more cloudy, the success rate of a goniolytic procedure goes down. However, if I can do a goniotomy, I will always do a goniotomy because it's so easy, complications are so low. Even if I've got a 20% or a 30% rate of success, I will try that first because it buys me time. And it gives me the chance of success as opposed to automatically converting to another procedure. So it's just a matter of philosophy. It has to do with the follow-up availability of the family, what the family is able to do, what you're comfortable in doing. And, you know, surgical comfort, surgeon comfort is as important as anything else. The surgeon has to be comfortable doing the procedure as well.
So,
So if you want to join the registry, all you do is email me, and we give you everything. It's very easy to do. We provide you with all the paperwork. You need to get your local institutional review board, research ethics board to approve it. It's all retrospective. You can do a prospective, but it's a retrospective cohort study that allows for slices in time. So we get the follow-up. So you can see where are 500 patients doing in 3 months, 6 months, a year, etc. So all you need to do is send an email and you're in. Everybody's invited. Everybody can participate. It's free. And then all the research data, if you want to analyze it, is yours. You don't have to put our name on it. It's all under your name. You retain all the authorship, all the data we give to you for free. We can even give it to you in tables and pie charts and bar graphs, and then you just write your paper.
You'll have to share your email with everyone.
Alex?
My last, sorry,
Okay. Let me just finish my email for her. It's alex_levin@urmc.rochester.edu. I'll give it to you afterwards. Okay. Doesn't matter. Email is, doesn't matter if it's capital or alex_levin, Levin, @urmc.rochester.edu. Yes, go ahead.
sir, what percentage of MMCs are using it? What kind?
That's, I use it so infrequently. But we use low dose and low exposure time. The most important thing with MMC is not as much the dose exposure, but how you put it on the eye. So we use Penn-Cause technique, the ring of steel. So we use a limbal incision, fornix-based limbal incision. I stick the pledgets way up under the conjunctiva because that's where you want it. I don't put it over the trap block, and I always put it in before I do my first incisions outlining the trap block. What do you use?
Same.
so
2 mg. I use 0.2 mg for 3 minutes in all
Yeah.
cases.
I use 0.2 for 1 minute.
0.2 per minute. And then on the larger area, I used to do it before in the past. I used to make flaps, but more I was doing trabeculectomy, I was getting 30mm eye, 39mm eye. So the sclera was so thin. So then I started putting it before making the flap into the large area. 0.2 mg for 3 minutes.
I like to tuck it up
Yeah, exactly.
as away from the flap as possible because the flaps are going to be thin in these kids as is. So I don't want any, so I've seen these buttonholes, scares me. So I just kind of tuck it all the way up in the conch, away from the flap. But I know a lot of people who just do it on the flap also.
So under the launch also with the flap, but I have never seen buttonhole in it, right? Because I have done brioches on my staircases, on the same spots also. It's fibrosed, as if I have not done anything. The sclera is there without fibrosis.
I've actually had the unfortunate pleasure of seeing mitomycin applied over the trap flap, and the trap flap completely necrosed, leaving a full thickness hole in the eye. You got to get it up away from the flap.
Yeah.
you can get the thin flaps like that with mitomycin, and that's here on.
And I must say, again, I live in a different setting than here, for sure. The problem with a bleb like that is it's been shown in many papers that the risk of infection and leak is cumulative year after year after year. Our patients are going to live 100 years. 100 years, that's the joy of pediatrics, right? So you're doing something to set them up for the rest of their lives. You don't want to get a bleb like that for 100 years. And you can avoid a bleb like that by using the technique of putting it up very high, away from the flap. You will not get a cystic bleb, and your bleb will be more diffuse and low-lying, but it will work very well for a longer period without the conjunctival complications.
So coming back to goniotomy, what are the determinants when you say that my surgery is successful or it's failed and I need to add something or I need to do the redos?
Yeah, I mean, if we had a universal standard for what is glaucoma or for what is success, it'd be a lot easier, but we don't have that. And for me, the least important thing, again, is the pressure. The most important thing for me is how's the eye doing? How's the cornea doing? If the kid still has corneal edema, I'm not winning. If the cup is getting bigger, I'm not winning. If the axial length is getting bigger, more than I would expect for growth, I'm not winning. So I think it's really important to take the whole eye into consideration rather than just the pressure. So that's my determinant. 60% of eyes after every single glaucoma procedure we have in childhood require medications to work. So I'm always going to add on medications after a surgery before going to the next surgery. And then I do it when I need it. You know, and the reverse is true. I just had a case last week of a kid who I did cataract surgery on when the kid was an infant. He's now 13 years old, and he's got glaucoma following cataract surgery. And he's been through so much in his life. He is so traumatized by all this experience of a lifelong, and he's had family problems, and there's other reasons. He's an injured child from his whole life story, not only his glaucoma. And his pressure was in the 20s, and his optic nerve is stable. His diurnal curve is good. And I said to the mother, I said, I think your whole child as a human being has more to lose from surgery than they gain from surgery. Let's just watch, follow him closely, see what his OCT does, see what his optic nerves do, and let's just watch. It's better for his mental health than going ahead and putting him through surgery, which he hates.
So for me, the people I trained with, they swore on retinoscopes. So I really like to do a retinoscopy and see how the axial length is changing, whether the myopia is going on or not. Because with optic nerve in kids, there's a lot of elasticity initially. Sometimes you see big cups, you do a surgery, and then the cups completely go back to normal. So there's a lot of plasticity. One thing that I found to be, of absolute importance, as is everything else, is your retinoscopy. So that gives you an idea of your axial length. It gives you. So my mentor and his mentor, they used to say, if you're stuck on an island, the one instrument that you should have is a retinoscope. So that's what I swear by also.
Rightly said, rightly said. We have a very busy schedules and we have a workload, extensive workload. So how frequent you arrange the follow-ups of these kids after surgery? 4 weeks, 6 weeks, 1 week?
I see them on one day.
1 day, okay.
Then I see them within 5 days because the highest rate of endophthalmitis is 3 to 5 days post-op. Then I usually see them a week later and I space it out from there. I base my follow-up on how the kid's doing. I have no strict protocol, but it also has to do with how far they travel. Some patients fly to see me from far away. So all those things are taken into consideration. The bottom line is they need follow-up.
Yeah.
And nothing is more upsetting than a person who's had a good surgery and then doesn't come back for 6 months and then they got troubles, right? So
So someone's stable. Are you seeing them 6 monthly or?
If they have a tube, I don't go more than 3 months. If they don't have a tube, usually 4 months if they're stable.
4
and
months
they're-
after this?
yeah.
Okay, let's add to our knowledge about the other case. 30 months old baby girl, if brought to you with a complaint of watering from the left eye, and these are the parameters: 9 millimeters cornea diameter in the right eye, and the 40 millimeters in the left eye. She was having unilateral glaucoma. 0.9 Kaplis ratio on the left side, myopic shift, and long axial length. So, what would be the choice in this cornea, goniotomy or trabeculotomy?
It's funny, what I was thinking here was, this kid's doing pretty well. Cup to disc is 0.5 in the right eye. The left eye is the problem eye. Obviously, there's been a lot of damage. The pressure, I don't know what the corneal pachymetry we haven't managed. That's going to be very important as well. But it looks like this child has had glaucoma for a while, for sure, in the left eye. If the child is still symptomatic and still having watering and so on and so forth, then clearly something needs to be done, although Hopstry alone can cause photophobia. So I think the first thing here is this glaucoma still active?
Yes.
That's the first thing. If you believe that it is still active, and I'd like to know the pachymetry, of course, 20, if it's a thick cornea, that may not be so bad. I might choose to put this kid on medicine and just follow this kid for a little bit. I have to prove to myself that this is not a spontaneously resolved glaucoma and that this child does need surgery. That's where I would start. In answer to your question, though, I would do a goniotomy in this case.
You'll go for goniotomy. Dr. Ali,
I agree.
you'll
See,
go for goniotomy.
No, I would first try to see whether this is progressing or not. See, you have to understand glaucoma is a progressive disease, and in adults it's progressing. In kids, sometimes there's spontaneous resolution also. So I need to be absolutely sure that this is an active glaucoma. So I agree. I would probably see this kid back after 3 months to see what the retinoscopy is, what the pressures are.
With the 0.9 of
I
cup
would,
disc ratio.
yes, even with the 0.9. And I would also,
And do you think that this 20 millimeters of mercury is not the target pressure? It's
I
not
don't know,
the safe?
I don't
because-
know what the corneal thickness is. See, your
Yeah.
IUPs are based on your corneal thickness, right?
Yeah.
So I don't know whether this is false high or not. So I'd like to see that. So, this is, for want of a better thing, this is not completely investigated just yet for me to take a decision. So I'd want to get the pachymetry. I don't think there's going to be too much of a damage in 3 months. If I want to be more aggressive, I probably see them after 6 weeks. But
Put
I
them on
think-
some medicines, probably.
Yeah.
Just to,
Yeah.
yeah.
So Dr. Asma, want to share something? Comment?
There are 4 of us, by the way, so just.
He's saying that we're going to put this patient on medical management for the time being. See what concerns it or not, would make ourselves sure of this. If it's actually
No, so it might be glaucoma, but whether it's still active, that is the question.
patient on any anti-glaucoma drug. So if the pressure is like this is 20 on after 3 months, I use single drug and it says 80. So how am I knowing that is this the drug acting or is this the spontaneous thing working?
So the progression will depend on the increase because child is still 13 months. Right? The glaucoma will happen 20 years. So if it is progressing, then the total diameter will increase, the axial length will increase, you will see the time of progression.
But I'm also using the
You
drug.
you ask a very good question. And the question is, we sometimes, like the parents, are on the edge of our seat. Well, what's the number? What's the number? 18? 18? 17? Is it? So if I have a concern that my pressure may be a little bit abnormal, maybe not, one thing I'll do is a diurnal curve. I'll see the kid 4 times in the day, 8 a.m., 11 a.m., 1 a.m., 1 p.m., 3:30 p.m. The reason is I want to know, is that 20 the top of the kid's day or the bottom of the kid's day? The kid comes in and the pressures are going up to 30, that's different than if the 20 is the highest and then 14 the rest of the day. So that's one piece of information you can use. Another question is you're looking at all the different parameters here. Am I changing this eye in some other way? In other words, is the cup getting bigger or smaller with medicines? Is the refraction getting bigger or getting more length? You have to see, is there signs of progression as a measure of whether or not your treatment is effective?
Is it the stability or the progression we're going to talk about? Because even if it stays stable after 3 months,
If it's stable, I'm happy.
Stability.
then
Stability.
we think that the drug is working also.
Doesn't matter. Doesn't matter what's working. What matters is that it's stable.
When you say that the disease is active or disease is not active, and if it's like
If it's with the medication, the parameters are stable, means the disease is not active?
No,
That's what you're
if you're
saying.
not getting worse, then it's not active. Then you have it under control. So if it's stable, right? Stable is good in glaucoma. Glaucoma is otherwise a progressive disease. You're never going to cure glaucoma. There's no such thing as a cure for glaucoma. Even if you have, you do goniotomy, do surgery, and there's no medicines post-op, you're never cured. It can always come back. So stable is good, right? And I think that worries us is putting a baby on a medicine unnecessarily for the rest of their lives, right? That's why I'm trying to be judicious about that. I only want to, and if I can keep it stable, then they'll stay on the medicines.
Worried about the 0.9 CD ratio.
You're right. When the cup is big, you're right that the bigger the cup, the more dangerous the situation, right? This 0.9 didn't happen yesterday. It happened for 13 months. It's been happening. But where are you at today? I see patients who have 0.9 cups who have their glaucoma's over. They're spontaneously resolved. I still follow them. I still treat them, but I have no evidence. Let's say this cornea is 800 millimeters, right? Micrometers. 800. That pressure 20 is probably okay. Corneal hysteresis is abnormal with the Hofstrea. Probably that pressure's okay. Maybe I'll drop it down to 15 with some eye drops. But I'm not going to do surgery unless I know it's active disease. And it doesn't go from 0.9 to blindness. It's going to go from 0.9, little corneal edema, some little change. Any little change is going to make me more aggressive. But I need to know that it's changing.
Sir, but still 20 pressure is not normal for a 13-month-old child. It should be in early teens at this age.
No, first of all, again, without the chemistry, we don't know what the real value is, firstly. And number two, we get so hung up on numbers. We get so fixated on numbers. Look at the whole eye. Is the whole eye, if the kid's got tearing down and watering, is there edema, corneal edema? I can't see it here. Maybe there is. These are the kinds of things I'm going to consider.
So if it's just scarring and opacity and no edema, so it goes in favor that it might be an inactive disease.
Maybe inactive, yeah.
Usually in our part of the world, it happens post-operatively. Usually. This scenario is presented as if something had happened before, right? But if the disease is active, as Dr. Levin said, you will find high pressures as well. Because glaucoma is not going to be controlled with 2 drops and, it is going to remain inactive. Either it has been arrested or it is going to show up.
So
what I think on follow-up.
What is the role of gonioscopy in this type of situation where you get a peripheral clear cornea and you are thinking about the stent resolved so
Gonioscopy.
is there any role of gonioscopy?
Yeah.
Yes.
Every child I'm seeing at first, I want to get a view of their angle. If I can get a view of their angle, I'm going to see the characteristic features of a goniodysgenesis like we see, those high patches of iris insertion, the immature development of the angle. I might even find posterior embryotoxin that wasn't easy to see clinically. That would certainly change my whole approach to this, right? So gonioscopy is always a very useful tool. It's one of the pieces of the puzzle.
So before starting any medicine, I'm deciding for the surgery, this is not necessary to go for the colonoscopy and see the status of the angle.
Yeah, so, what does it take to evaluate a child? I usually do an examination under anesthesia. I think it's a invaluable tool because then I can get all my pieces together. When you're making a puzzle at home, a picture of the map of Lahore, you're doing a puzzle. The more pieces you get, the more you eventually recognize what you're putting together. So I'll do an examination under anesthesia. I'll get corneal I'll get OCT, I'll get photos, I'll do gonioscopy, I'll do refraction, retinoscopy. I'll do all those things as a measure. And if I want to do it again in 3 months, I'll do it again in 3 months to see if anything's changing with or without medicines in the interim. But those things are invaluable. And the risk of an examination under anesthesia in 2025, it is more risky to drive to the hospital than to have anesthesia. So I use them freely and openly, and I find them very, very helpful.
Sir, mere presence of posterior embryotoxin, does it change your diagnosis? Because it can be present in a certain percentage of normal population as well. So if there are no other iris abnormalities, will you label it as a secondary glaucoma due to accentuated rigor?
That's a very important question. So why do we bother? Why do we even care what the cause of glaucoma is? We care because surgically it guides us, medically it guides us, and for the family it guides us. The inheritance pattern, what's the risk of recurrence? If you're doing genetic testing, all those things spill out of knowing what you're dealing with, right? That's what phenotyping is all about. If I see posterior embryotoxin, for example, and I'm thinking Axenfeld Rieger, then you need an echocardiogram. You need to look at the rest of the body. There's other things associated. If I see Axenfeld Rieger, I am not usually going to do a goniotomy or a trabeculotomy. That's a relative, I wouldn't say contraindication, but it's a concern depending on what the angle looks like. So those things are important. That's why I'm always trying to get a full picture of what's going on. I would say, though, that yes, 20% of normal population supposedly has posterior embryotoxin. I think that's the number in the literature. It's a little high. But those patients are all at risk for glaucoma because it's a marker of angle maldevelopment. So this kid, he's got a big cornea, 14 millimeter cornea. He's obviously got glaucoma. So if I see posterior embryotoxin, it's not a normal posterior embryotoxin. It's a posterior embryotoxin in the setting of glaucoma. Right.
Okay. Dr. Sudas, let's discuss a little bit your experience with the trabeculotomy. Trabeculotomy.
I do trabeculotomy as a combined procedure with trabeculectomy. If I make a flap, so when I'm making a flap, disturbing the bond, making a flap, and utilizing that site, then I get maximum benefit out of it. So I always combine with pounds, modified pounds trabeculotomy. I do trabeculotomy first, and then trabeculectomy.
So,
obviously with my tomography.
So what about the post-op hypotony in combined trab with versus the combined trabeculotomy trab or a single procedure?
Hypotony is always a threat with trabeculotomy, lectomy, and tubes, right? So it's our surgical steps being modified. So when I make the flap, I don't get the radial cuts to begin with. When I make the scleral flap, I don't go straight away to the limbus. I go slowly and gradually. Temporal leakage is more responsible for the, you understand what I mean? The radial cuts we make. So I don't go close to the limbus. I mean, away from it because the lateral flow gives you hypotony. The posterior flow is required. So even if I have to proceed forwards toward the limbus, if I make the cuts, I suture them. Okay, so I prefer perioperatively posterior flow from the posterior side of the scleral flap, right? And when I close my scleral flap and my AC is getting shallower so quickly, that means post-op I'm going to have shallow AC, right? So then I modify my sutures accordingly. But if I put too many sutures and then again I monitor my flow. So I want a diffuse flow through the posterior lip of the flap and AC is not shallowing so quickly. It remains formed. But I don't want firm eye. right? So I gauge the flow of the flap per-operatively, and after doing so many TREBs, I come to know that next day I'm not going to have shallow AC. But at the end of the surgery, I do leave air bubble, which guides me. And even if the AC is shallow, that air bubble is going to help me, see, to avoid this lenticular touch, which is more important, and getting the choroidals. So if your AC is moderately shallow post-op, that's a good sign. And if you're having limited choroidals, they will go away. Just give atropine, steroids, follow-up, they will go away. But modifying the flow per-operatively is very important, not to get severe hypotony that you have to go to OR next day to form the AC because of the touch, right? So this is how I gauge my post-op hypotony based on the per-op suturing of the flap.
I have a different technique with the storage treatment. So I used to apply one tight suture and one little bit relatively loose suture on the other side. And after holding the conjunctiva, then I used to check the stability of the anterior chamber tap. If anterior chamber loses so rapidly, then I again open the conjunctiva and tight the other suture as well. So after holding the conjunctiva, feeling the conjunctiva, if the chamber is stable, it's not shallowing at the chamber, and your flow is coming beneath the conjunctiva, and there is emotion of conjunctiva by injecting the fluid AC, then I think so. These my patients don't show shallow chamber in post-operatively, and they don't go into the until and unless you cover with the conjunctiva, you will not. I think my experience. You will not be sure this trabecular filtration blade will work or not.
I do something very similar. At the end, after I'm closed, I put fluid in the anterior chamber to see what it looks like. You know, this conversation is very fascinating to me. Dr. Mandal is a dear colleague, a respected colleague, and he's the one who came up with trabeculectomyotomy. And every time I'm with him, I say, gosh, you know, it's amazing. Your results are so fantastic. No one in North America, or virtually no one in North America, does that operation, trabeculectomyotomy. You don't see
You
it.
don't have any other choice.
I know. And it's very fascinating, the two experiences, right? On one hand, an operation that's used very commonly, and in the other place of the world, not at all. And certainly, when you don't do that operation, this conversation is moot. No one's discussing hypotony after trabeculotomy. No one's discussing hypotony after goniotomy. We're only discussing it after you add the trabeculectomy. And I've always asked Dr. Mandel, I said, it makes no sense to me. If you do an otomy-ectomy, fluid will always flow to the path of least resistance. So the fluid is going to go through the ectomy. It's not going to go through the otomy. What's the purpose of the otomy if you do the ectomy, right? But that's an experience you all have that I don't have. I've never done that operation. No one I know in North America does that operation. It's just a different world, different experience. And I'm grateful to have you, and maybe one of these days I'll try it.
No, Dr. Levin, when we start doing trabeculectomy, this hypotony, that it doesn't let you sleep, you know? But when you are an expert, when you do 500 trabeculectomies, then I go home and sleep, and tomorrow morning, and oh, I have a post-op. Oh, really? Open the pad now, and the AC is formed. But I do, I would add to one point here. I gauge my scleral sutures, the scleral flap sutures first, then I hood, and again I inject to see the bleb, right? So I do it at the end, which is the common, which everybody does, right? This is the part and the parts of the trabeculectomy to make the bleb at the end of the surgery, otherwise it is gone, right? But the extra thing I do to gauge the flow of from the fistula to avoid hypotony is to monitor my sutures before putting the flap, and then after it's the
Do
part.
you use the MMC when you are doing the trap?
Yes.
So at what time you
Before making the scleral flap, I told you that before I used to apply under the flap, but I was doing more trabs, and everybody is sending trabs to me. So doing like trabeculectomy in a 30 millimeter eye, 31 millimeter eye, 29 millimeter eye, the scleras were getting thinner. It's really a thin film. So then I started to make it before making the flap, because if the perforation is there, then you can't apply MMC, right? So now it's my even if the eye is 22 millimeter, I put it on the top before making the scleral flap.
Thank you. Dr. Taiwa is getting excited, I think. Yeah.
Is there any role of releasable sutures in congenital glaucoma tuberculosis in congenital?
Well, people who do it, they favor it. I don't do it, so I don't have any experience. Sorry? You are doing it or you're very happy with it? Okay.
How are you doing it?
The proximate type suture and the other one is suture. And I leave the, I use trigunite, so it's on the limbal side. If the pressure is normal on the second horoscopy, I mean, I sometimes remove it. If the pressure
Remove
is
which one, the tighter one or the?
The loose.
the loose one.
While the she's awake,
Are you making this,
triangle.
so you're making a triangle? So
Yeah.
the apex
Yeah.
has a heart.
One is X and the other. This one is the normal type suture and the other is the removable suture. So I leave the end on the corner, and when the pressure is high, so then I remove it. Otherwise, I remove. If it's normal, I remove it.
And you do it by putting the tape under or?
Yeah, under.
one thing that I just like to add is patience. Patience is sometimes the best treatment we have. I have seen kissing choroidals go away.
Yes, yes.
Shallow anterior chamber
Yeah,
will deepen with time. High pressure, sometimes you just have a little clot in your sclerotomy. It'll go away. So I try not to act too hastily.
Yes.
Not too quick.
For sure, yeah.
I'll use steroids for high pressure after surgery because sometimes you're just getting rid of inflammation or blood. I wait. My mentor once said to me at the end of surgery, I asked him why he wasn't fixing something. And he looked at me and he said, God is a good surgeon. Right? Allah is a good surgeon. Things get better. And I think we all have to just take a step back sometimes and let nature take its course and help it a little bit with some medicine.
So
Okay,
with kids, with
What
kids,
is the collagen implant during pregnancy? I did about 10 years back. Collagen implant.
What kind of
So what,
plans?
collagen, that like Ologen. Yeah. So what were the results? Did you find any difference?
There was no difference.
There was no difference. There was no difference. I did few cases at civil hospital. Didn't find any difference. And then there was a way of doing injecting MMC before the surgery. I did that also. 70, 80 cases. Yeah. That 0.2 ml, 10 units, you just inject MMC in the conch before doing surgery, before opening the conch, and then spread it over the conch and then wait and then perform the procedure, right? It doesn't help.
Is there
Doesn't help.
anyone having the experience of injecting anti-VEGF 2 or 3 days before the surgery? We have done in 10 eyes and it's really good.
I know in
It's
more
good.
fields they are
Yeah.
doing that. I heard the talk,
Yeah.
but I haven't used this.
I've done in center in 10 eyes and it's really, the outcome is really good from the surgical point of view, success
how
rate.
long have you
Yeah.
followed them?
Sorry?
How long have you followed them?
2 years.
And you did not use MMC or you were still using MMC?
No, I didn't use MMC.
So you're basically substituting.
But in 2 of the
VEGF.
patients, then I had to go in and use the 5FU in the plaque.
So I
But
usually am
it's
not
a
so
sample
scared
size
of-
is so small that I'm not still like publishing it.
Just one injection of
3 days before,
Just one?
yeah, just 0.625 milligrams of Avastin when the Avastin was available in Pakistan.
It still is now.
So
it's almost, I think, 2
yeah, but then after 2 to 3 days before the surgery, so after that I go in and did my trap, and the results are good.
I would just,
In 8 of the babies. In 2, I have to go again. I'm routinely using the MMC. Just these patients I've done Avastin and didn't use the MMC, and my results with that one is comparable and significantly better than my results with the MMC.
What is the safety?
But because of the small sample size, I'm not discussing it further here. I will do it because there is a complication rate of low, and the outcome is good because the success rate is good. I had to in one patient, two patients where I gave 5-FU in the blood, and in one patient I had to start beta blockers after 6 months, but 7 patients are fine for 2 years follow-up. Yeah, in the blood, there was a, yeah. After 3 months. I gave the anti-VEGF at the site where I was planned to go in to make the blood. So it, sorry? Yeah. Injected into the bleb afterwards, where I found that it's going to fail. The bleb was failing. So
I was just going to say that research is an important tool. I'll talk about this when I talk about I'm going to talk here on ethics of innovation. We have to be careful. This is a fantastic session, hearing everyone's experience and all that. But we really have to be careful that we try and gather data to justify what we're doing. And it's so hard to do in a rare disease, so very hard. And we're so tempted, we're so frustrated by this darn disease that makes kids go blind. We want to help, we want to do the right thing. We should try and collaborate together to find a way to think about all these good ideas, try and test them rigorously, rather than just trying stuff. It's so hard when you're dealing with a incurable disease to know what the right thing to do is.
you're right. Yep. So Dr. Ashal, a panelist here, because he was not there at the time of the introduction. He is a known pediatric ophthalmologist and working in KEMU for the last 24 years. Dr. Paul, because I've worked with you, I know that you do the trabeculotomies, but you don't make the flap, conjunctival flap. So would you mind share your experience with the trabeculotomies without flap? You just give the you remove the conjunctiva, and you, I don't know how do you identify the Sherm canal without?
No, I do it routinely, but I do it the way the standard procedure is. I give a conjunctival flap, I give a conjunctival incision, and then I make a small flap, and then I get in. I don't use the sutures, the Prolene sutures, but the other procedures are the same as the standard procedure is.
Okay.
And I'm good with it. But obviously, they do not work when the glaucoma is of moderate to severe intensity. Mostly, they control the pressures, and the pressures are below like 20s, like 25, 26, 27. Then they do well. But if the pressure is 30 and more, I combine it with trabeculectomy.
This pressure 20 millimeters is with medication or without medication?
It's without medication, because then the pressure has actually to be in the like 11 or 12, or it has to be like that, and the pressure is in 20. So then I go trabeculotomy. But if the pressure is like in late 20s or 30s, I combine it with trabeculectomy.
I have some, very commonly, we all know that the cornea size is big. What about to find the proper surgical site to make the flap? Any technique, any tips, any pearls? So how to get the better surgical field to make flap? Because the cornea is going, in Pakistan, we usually come across the corneas of more than 14 millimeters. Small eyes, big corneas, no surgical field, and we have keep on fiddling with the conch, with the eye movements. So any tips?
Yeah, I would.
I
Yeah.
use a bridal stitch. Superior rectus, I find very useful. Some people like to put a 6-0 right go through the limbus as a
Yeah.
cornea, bring the eye down. But having some method to pull the eye down, expose the field is very helpful.
Yeah.
I love the Burden suture superior rectus.
It's
I
good
don't-
because it supports the sclera.
That's
too.
right. And I don't want to play too much with the corneas.
Yeah, I used to do this superior rectus a lot, but I used to get bigger and bigger corneas. And sometimes with the superior rectus, there's a bleeding as well. So then I switched to putting 7-0 vicral suture, like slightly anterior to the limbus, not at the limbus. And that works very well. You can bring the eye to 6 o'clock. You have a big, big field to play a sixer even.
So you are putting the suture on just slightly on the limbus at 12 o'clock.
Anterior to the limbus, yeah.
Anterior to the limbus
yeah.
at 12 o'clock.
Yeah.
And so.
And then
when-
bring the eye down.
When
bring
you
the
are
eye down.
going inside to make the iridectomy or iridotomy, so doesn't it impede your
No,
visualization?
not at all, not at all, not
One
at all.
little trick is if you put it through, right, instead of taking the two strands and bringing them straight down over the cornea, which can dent the cornea,
Yeah.
spread them out so they come down like this,
Yeah.
and then you won't crease the cornea, right? That helps.
Yeah. Because yes, when there is an edema, it indents the cornea when it is across. So yes, it's a wonderful tip. Yeah.
So,
But it doesn't impair it doesn't stop you doing a iridectomy or anything, no.
Makes it easier.
Makes it easier, yeah, you have a big field. You can make 4x4 flap very easily.
Speaking of surgical technique that is involved in trabeculectomies, I have a question from Dr. Madam, is there an effective way to approximate the conjunctival flap after the surgery has been done, after the travel has been created? Because many a time I find it difficult to approximate the conjunctiva after the surgery has been completed and there is leakage from multiple areas. So I'm planning to do at multiple sites just to ensure that blood is created and there is no leakage. So is there any effective method to approximate the conjunctiva?
I wish I had a video presentation. I prepared one, but it was not accepted maybe. But there's a way. You just open it from 12 o'clock, okay? Then do the dissection and give small radial cuts. It's open up very nicely, and when you're approximating it back, it approximates very well. I never had this problem of having buttonholing, or I can't approximate the two edges of the conch. No, never. And the success of the surgery depends on when the conjunctiva is properly approximated to get the good bleb. Okay, and then do good dissection. Don't
And
be
I
afraid
would
of the
add that be careful when using your cautery, and be careful when using the MMC. Don't touch the edges of the conch.
I also, over the last many years I've been doing this, I use less and less and less sutures. It's interesting. I used to be so afraid of the leak in the limbus. I would put a running suture over, and over the years, I don't know how, it just sticks and it stays. So I do exactly what you do, radials. I close my radial. I bring up the corners. If there's a sag, I'll bring up the sag, but I don't put a lot of sutures in.
There's one more tip. I leave a frill of conch. When I open the conch, I leave a frill of conch near the limbus. And then I approximate this frill with the rest of the conch. See, so conch to conch, it's not the conch to limbus. People do that also. People shave the limbus and then they apply conch on the top of the limbus to form adhesions. But no more in practice. They're just, yes, just a frill so that you can take bites through it. Then sometimes it's a C-shaped, right? But to put more MMC, these pledges, then I give some radial cut sometimes. And then the approximation is good. Yeah.
On both sides, so that I can just lift it like an apron.
So you do fornix base or limbal base? Fornix.
So basically what the take home is that there's small nuances. Everyone does it in a different way. At the end of the day, you're going to find out what works for you. And you also have to trust that the fibrosis and healing is much rapid in kids than others. So if you see that small little leakage per hour, let it be. It will settle, and it usually does settle. Same is the case with hypotony. The first day or two of hypotony doesn't really worry, because there's so much fibrosis that's going to happen, and it does jump back. So, unless it's a 1-2 millimeter of mercury, I'm not too worried.
So, do you do the pressure patch if you get the hypotony? Do you do anything?
Not for.
Or atropine, or what
atropine?
atropine?
No,
Yeah.
I don't do it. Do you do it?
No, I think pressure patch makes it worse.
Yeah.
But you know what's interesting? So the four of us probably have over 100 years of experience. And there's certain things which we all do the same,
Yeah.
right? We all make the same, we all talk about the same limbus incision, we're all talking about the same weighting. It's these things that somehow over our years of experience have crystallized out. Those are the key things, I think.
Yeah.
There must be something right about if we all wind up doing the same thing, practicing in 4 different places in the world. So I don't use a pressure patch. I use my incision the same way you do. Those are the things that really fascinate me. Yes, there's other ideas, this injection, that injection, but this groundwork is pretty stable. It must work.
You go for an intraocular pressure check on the second boost of the
No, not at all.
I don't even
Not
check
at-
the pressure.
Not at all.
The pressure is the least important thing. I look at the eye. Is it deep? Is there edema? Those are the things I'm looking for.
Yeah, AC is formed, there's no lenticular touch, that is more important. Yeah? If there is a lenticular touch, you have to take child to OR and form it.
My post-op examination on day 1, it takes about 2 seconds. I look deep and I'm done.
And then you say thank you to God. Alhamdulillah, that's fine. Just steroids and atropine and things like that, and come to
Dr.
me after
Sudat,
3 days. Let me sleep for 3 nights.
Dr. Sudat, you mentioned that you use air bubble. Do you have any experience that sometimes the air bubble go behind the iris? And,
No.
And because I have in 2 of my
If it
patients,
happens-
and it's like
if it happens-
2 a.m. I'm getting the call from that the
it
child
hap-
is vomiting and something.
If
like
it
that.
happens, then just supination, put the dilating drops, it comes up. You have to gauge
Yeah.
your, the amount of the bubble.
So I have different experience of making trail of conjunctiva. So I found when I'm doing this for the previous day, so you need to apply the filter between the conjunctiva. This induces very good foreign body reaction, and these traps get failure earlier.
Which
So
one,
when I
sorry?
switched myself to shaving of conjunctiva from the temples and putting back the conjunctiva of the temples, I found these patients have less chances of foreign body reaction related to the suture material, and their failure rate is pretty low.
No, I don't leave the big probe. It's just like half a millimeter just to engage your needle. Yeah, I don't apply it on the cornea, no.
So usually it's conch to conch.
Yeah,
That's.
yeah. If AC is formed, it's hypotony and the choroidals are there, they will settle. They will settle. Wait, patience.
Patient.
Wait, yeah, wait. Sorry? If it is too shallow, it's grade 3, you have to form it.
Still wait.
Because if too much shallow AC and there's touch, but besides that, if it is too shallow peripherally along with the touch, this contact of this your fistula and this flap, it causes adhesion, and then your inner fistula will fail. There will be fibrosis there. Okay, to keep it working.
If 4 people are, and we're all saying, wait, it's a lot of experience here,
Yeah.
saying, wait, be patient. God is good.
Anyone have a experience with the flap, rectangular and triangular flap? Triangular flap, any one of you make the triangular flap, circular flap, partial thickness? Yeah. Yeah. Okay. So, a very interesting discussion was going on, but we are over time now.
This we have Friday prayers.
Audience, any questions, any feedback? Okay.
So, I have a patient on whom I performed combined trabeculotomy with 4 months of pain, now he's around 8 weeks old. one eye is doing very well, its pressure is controlled, maybe even the cupping can be worse. But the other eye, I did then trabeculectomy, then I did cyclodiode, I think 2 or 3 times, but still it's not controlled with, and leave on all of these topical medications. It's still not controlled. I have referred one from aging for aging, but why is a difference in response between the 2 eyes, although both of the eyes were the same, meaning they were at the same stage of glaucoma, and one eye is in
It's
red and
because your eyes are not twins. Your eyes are genetically different. They're different in the response. They're never twins. Just look at the slit lamp at any individual. Their 2 eyes don't look like twins. So some eyes do better, some eyes do worse. There's an old saying, in glaucoma, you can do your best operation and get your worst results. You can do your worst operation and get your best results. Each eye is its own thing.
What about angles?
opulence.
So probably the angle maturity must be different. The more the immature angle is, the more poor response you will get. The more the mature angle
All
is.
the parameters for the same in both eyes.
But the problem is in congenital glaucoma, the problem is in the angle. That is the most important thing actually. So might be the reason, could be, you can find the reason
And we
there.
don't get the bony lens, so we rely on we can exclude the secondary causes for to label it as a primary glaucoma.
It's not too expensive.
Yeah.
You should get it.
Yeah, right. And so is it mandatory, is it always important to go for this if there is because in a setting where it's not available.
Or what? Go for what?
Gon- other than
Colonoscopy.
Fundamental. If you're doing glaucoma, it's
No,
fundamental.
it's for pediatric. If you're working for the
If you're doing
adults.
glaucoma, period, you need a
Yeah.
look at that. So I think that's fundamental. So, and it's not too expensive.
Yeah, I have my own. Yeah, I'm using that one. So we have learned so much things that it is difficult to conclude the points because we are already over time. I would just like to say thanks to all of you for such an interactive session. Thank you very much. Any feedback from Lemon? Any concluding remarks, please?
That's great.
Dr. Suyat?
Thank you very much. It was a wonderful
Pleasure.
session. We all learnt a lot from each other. And it was an interactive session.
Fun, wasn't it?
But
Great to hear.
Okay, thank you.